All right. So, greetings everyone. It is my pleasure to welcome all of you in the second virtual GenCon research talks and workshops this fall semester. Research talks are short 20-minute presentations followed up with open discussions since there's only five of us that will play with it. But I hope that this recorded presentation will give more information to others who are interested in this topic. So questions will be entertained right after the talk. So you can raise your hand or type your question in the chat box. My name is Joseph Yap, and I am from the library and as part of the executive team. I am co-hosting this event with Jana Izikinova. So for those who are new today, the Consortium of Gender Scholars, or GenCon for short, exists to bring together and support gender scholars in Kazakhstan and those who study in the Central Asian context. The primary purpose of GenCon is to generate research designed to make meaningful change in various areas of society with regard to gender equality and advancement of women. GenCon is interdisciplinary and based in Nazarbayev University. It's directed by Drs. Anna Cohen-Miller and Dr. Jennifer Lewis. So let's get moving. To formally introduce our guest speaker, let me pass the virtual mic to Jana.
Okay, thank you so much, Joseph. So today we'll have Dana Bazarkulova. She is Assistant Professor, School of Science and Humanities, Economics Department. Dana completed her PhD at University of Manitoba in 2014, and her work related to the field of labor and family economics. She has continuing research interest in the areas of work, family relationships, family resource allocation, time use, female labor study, and well-being. And she also would like to notice that today's work she done in collaboration with her other researchers, Galia Sagandikova and Jana Kapsalamova. So the floor is yours, Dana. You can start.
Thank you. And I cannot share my screen.
Okay. So I should.
Okay, I can see it now.
Okay.
Can you see my presentation?
Yes, perfect.
Okay, great. Hi, everyone. Thank you for having me at GenCon Talks. And today I will present a project titled Changing Personal Care and Healthcare Behavior by Physicians During the COVID-19 Pandemic, based on the evidence from Kazakhstan. In fact, together with my co-authors, we have a series of 3 papers on this topic, and today I will discuss findings of 2 of them because they're closest to the completion. Before I start, let me talk about my co-authors. Here is their names in the alphabetic order. So the first paper we wrote using this data and using this project is on gender effect of COVID on the well-being and behavioral outcomes, is co-authored with Janice Compton at the University of Manitoba. This paper recently was accepted for a publication in the Feminist Economics Journal and now is in production. The second paper on healthcare behavior is co-authored with Charles Becker at Duke University and Galia Sagandikova, who is professor at Nazarbayev University and my colleague at the economics department. The third paper, which we compare the well-being of doctors who are more likely to work with COVID-19 patients versus doctors who don't, is co-authored with Jana Kapsalamova, who is my other colleague at the Department of Economics at NU. So during my presentation today, I will briefly talk about objectives of the research project and shortly remind you how COVID spread in Kazakhstan in spring. I will assume that everybody who is who will be looking through this presentation later, they belong to NU and aware of how events developed in Kazakhstan, so I will not spend a lot of time on this. Finally, I will report the findings on two topics. I will talk about reporting stress and engagement in bad habits and changing personal healthcare behavior by physicians. Both topics use the same data and methodology, and I can talk about data and methodology in more details in the Q&A session, if there is any. And Galia and Janna are also here during the presentation, and they will join me in the discussion. So, the COVID-19 pandemic and the resulting economic shutdown have created increased stress for men and women worldwide. It also made us think twice about our health, access to health care, and preventive behaviors related to our health. For example, we now know that people with diabetes, cardiovascular diseases have a higher risk of contracting the virus and have worse treatment results. And maybe some of us may decide to go on a healthier diet or work on boosting their immune system to reduce the likelihood of catching COVID-19. We are interested in behaviors of doctors because those who work in healthcare may be more susceptible to increased stress and anxiety, especially if they have contact with COVID patients. Healthcare workers also have more information about treatment protocols, chronic conditions that worsen COVID-related illnesses, and their own health status. So in the first paper, we examine if the COVID pandemic increased the probability of reporting stress by doctors. Also, are there gender differences in self-reported stress and in participation in unhealthy behaviors such as smoking, drinking, overeating, and lack of exercise? In the second paper, we examine if there are any effect of COVID-19 on healthcare behaviors of doctors in Kazakhstan. In particular, we will ask the question, did doctors change the frequency of doctor visits? Do they change the probability of reporting self-treatment and informal health-related consultations with their colleagues? So let me briefly talk about the development of COVID-19 intensity in Kazakhstan. The first two cases of COVID-19 were confirmed on March 10th and 12th. And almost immediately, the government of Kazakhstan declared a state of national emergency, which lasted until 11th of May 2020. At the same time, cities and regions declared lockdowns at different times, and later these lockdowns were removed during the month of May, also at different times. At first, there was a very slow increase in number of COVID cases, with none in some regions of Kazakhstan. But during May, there were already 10,387 new cases in the country, with the highest numbers of new cases registered in Almaty and Nur-Sultan. And both cities had about 2,000 cases respectively. This diagram over here shows the frequency of COVID cases by week in May in the regions of Kazakhstan and Almaty and Astana. Although you might not see the details very well, but what this diagram shows is the intensity in different regions was different. And for example, we see the spikes here for Almaty, the spikes for Nur-Sultan, and from week to week, there was also a difference in COVID intensity. And here I need to point out that I restrict my discussion of COVID intensity by May and beginning of June, because this is when our data was collected. We didn't go beyond June. So let me describe you the data. Everything started in 2018 when Janna Kapsalamova and I started collecting the social survey of healthcare workers. Janna had a grant from the Newton Foundation, and she had decided to spend some money on the survey. Initially, the survey was planned as a cross-sectional, But in 2019, Jana and I received a small grant from Nazarbayev University, and we had an opportunity to administer the second wave of the survey. Due to the budget issues, we had to split the second wave of the survey between 2019 and 2020. As a result, we ended up with 2 waves of data, with the first wave from 2018 and the second wave split into 2 parts. The first half of the second wave was administered in 2019, I think in November and December, and the second half of the second wave was administered during COVID pandemics in May and June 2020. Originally, we interviewed 1,007 doctors, and about 50% of the sample are treated during the second wave. And this is probably the biggest problem with our data, is that the attrition rate is more than 50% of the original sample. Moreover, most likely the treated doctors are those who worked with COVID patients, and they could not respond to the survey at the time of the survey. However, we tested if the treated sample is statistically different from non-treated sample and did not find many differences. At the same time, we interpret our results with a caution. The doctors that were responding to the survey in 2020 do not necessarily have contact with COVID patients, and our result may have a downward bias. At the same time, our data is beneficial in many ways, and most importantly is that we have a panel data available. So we have a before COVID information and after COVID information. Another positive side about our data is that we did not include COVID-related questions to the survey, so the questions do not focus COVID-19 as a problem. So most papers on the effect of the pandemic on well-being and behaviors of doctors and population collect survey after the shock occurred. So they have a cross-sectional aftershock representation. With our data, we have a luxury to compare the aftershock outcomes to the before shock outcomes. So let me go ahead and show you the results of our research. And first I'll talk about the paper on reporting stress and engagement in bad habits. The doctors were asked to rate their psychological well-being and choose among the following answer choices. They could say that they are peaceful and calm, or they're anxious, have chronic stress and depression. In the second question that we used for this paper, the doctors were asked to report if they have bad habits, lack of exercise, and drug consumption. Of course, only a few doctors reported drug consumption, and we did not take this into our analysis. So let me show you the summary statistics. And first I will talk about women and then go to the men, because we focused our paper on a gender difference. Comparing data from May and June 2020 with the data from 2018, we see that the rates of stress and anxiety increased significantly for women and for men. So this diagram is for women. This is the reporting stress by women. And here's the diagram, similar diagram for men. And we also can see that men are more likely to report stress in 2020. So the gray bar here is for 2020. At the same time, we can see that there is a slight change in bad habits. For example, women report more smoking and they report more absence of exercise. For men, the numbers are a little bit different, but we still see the increase in smoking. We see increase in bad eating habits, and increase in the sedentary lifestyle. At the same time, we see also that the consumption did not vary, the alcohol consumption did not change much between 2020 and 2018. So these are visible changes that happened, but only when we report summary statistics. Whenever we include these numbers in the regression and we control our regressions for personal, job-related, and regional characteristics, unfortunately, or maybe fortunately, these positive effects are not proved to be significant. So when we control for personal, work-related, and regional characteristics in the regression analysis, the positive effect of COVID on self-reported stress comes out as insignificant. So maybe I'll go to the next slide where I wrote all this. Whenever we include controls in the regression, the outcomes are insignificant. However, then we decided to shift our focus on the family composition because recent literature shows that women carry heavier burden of COVID-19 compared to men because they have to take care of household and children. And what we found is very interesting. We found that family composition has a significant variable effect of COVID. For example, married doctors with children are more likely to experience stress and anxiety during the pandemic compared to unmarried women. Married women doctors with children are more likely to experience stress and anxiety during the pandemic compared to unmarried women doctors without children. This finding is in line with the literature on a dual role of professional mothers who have to take care of the family on top of their work responsibilities. In contrast, married men doctors are less likely to experience stress and anxiety during pandemic compared to their unmarried counterparts. For both men and women, the presence of a spouse lessens the likelihood of engaging in unhealthy eating habits during pandemic. But for women, presence of a spouse increases the likelihood of smoking during the pandemic. So there's probably some kind of peer pressure effect. And I personally find it very interesting that COVID has this universal effect on women with families in terms of levels of stress. And this effect is the same across countries and across professions. And it was confirmed by many other papers and many other research. Okay, so now let me jump to another paper. And in the second paper, we'll look at the personal healthcare behavior by physicians. We now know that COVID-19 has more dramatic effect on people with chronic conditions related to lung, cardiovascular, diabetes, and other illnesses. As a result, we expect that doctors who are more informed about risk factors will report higher frequency of doctor visits in 2020, especially if they have family and children. So the table here reports summary statistics for different years for two questions that we asked in the survey. Question 1 asks, when you feel sick, do you go to the doctor right away? And the respondent could answer that they either go to the doctor right away, not always go, and don't go to see their doctor at all. We see in the summary statistics that while doctors in 2020 are more likely to respond that they see doctor when they sick right away compared to 2019, the proportion is almost 3 times smaller compared to 2018. So I'm looking here at these numbers. So we see that doctors respond that they want to see their doctor right away in 21% of cases in 2018, and it fell dramatically to 2.7% in 2019. Then In 2020, the proportion of these doctors increased to 7%, but still didn't reach this level of 2018. At the same time, when we add controls for personal, regional, and job-related characteristics in the regression analysis, we do not observe any change in the behavior of doctors attributed to the COVID pandemics. So this difference doesn't seem to be affected by the COVID. Then we analyze responses of doctors to the following question. What are the reasons of not visiting your doctor when sick? And the answer choices included self-treatment, informal consultations, treatment abroad, lack of health insurance, and mistrust to the healthcare system. So most frequent answers were self-treatment and informal consultations, so we report them here. It seems that the doctors in our survey increased both self-treatment and informal consultations between 2018 and 2019. But in 2020, they decreased both self-treatment and informal consultation. Compared to 2018, doctors who responded to the survey during COVID reported that they increased informal consultations with their colleagues, but we found no effect of COVID on self-treatment. So we have this increase from 2018 to 2020, and it's statistically significant in the regression analysis, but the difference of the self-treatment between 2018 and 2020 is insignificant when it's controlled for other characteristics. So this is another interesting study, is that although it makes sense that the COVID would somehow change the behavior of doctors themselves, whenever they feel sick, they should go and see the doctors right away, or at least they should improve the frequency of doctor visits. But it doesn't seem that COVID had this effect. And another is that our doctors in Kazakhstan, they increased the rate of informal consultations, but they still do self-treatment at about 13% rate. We finally add some, let me stop here, this slide. We finally added family-related characteristics to the regression analysis, expecting that the healthcare behaviors will change in the presence of spouse and children. We found some weak results that doctors with children are less likely to report self-treatment behaviors, and single women decrease informal consultations with their colleagues as a result of COVID-19 pandemics. So they are not the results are not extremely significant here. So in conclusion, we can say that we did not find strong evidence that doctors in Kazakhstan changed their professional, personal, and health-related behaviors as a result of COVID-19 pandemic. When looking into the well-being and adverse behaviors, we'll find the protective effect of marriage for men doctors. Unmarried men are more likely to experience stress and anxiety and engage in poor eating habits during COVID-19 compared to married men. Conversely, unmarried women doctors are less likely to experience stress and anxiety during COVID-19 compared to married women with children. And while marriage reduces the likelihood of women doctors engaging in poor eating habits during the pandemic, it increases the likelihood of smoking. When looking at one's health care, when looking at one's own healthcare behavior, we do not find a significant change in the frequency of doctor visits by respondents overall. Doctors surveyed do not change their self-treatment behaviors as a result of COVID-19 by significantly increasing formal consultations with their colleagues. Finally, there is some policy implication, I guess, and the results suggest that the policies to enhance the well-being of doctors during pandemic should consider both occupation and household stress. And another policy implication of the second paper would be that there should be an increase in accessibility for healthcare related consultations for doctors, and probably more formal accessibility would be welcomed. So that would be it. Thank you for the attention. And now I will take questions.
Thank you so much, Dana, for your presentation. I found it very engaging and valuable, your empirical data. So I have like two questions if nobody willing. Joseph, do you want to ask something now?
So too. Yeah,
You have a
yeah, I
question too.
also
Okay,
have a
okay,
question.
okay, you can go
Oh,
ahead.
Me, okay. So thank you, Dana, and your colleagues for doing such research, which is important in Kazakhstan during the COVID-19 situation. My question would be, in general, what specific factors or events that happened during COVID-19 that made them stress, those doctors, either they're married men, or married women, or unmarried women? So what are those specific factors or events during those times that made them anxious, that made them depressed? Because I haven't seen it in the report.
So the stress factors obviously include occupational stress factors, because many doctors, whenever you are a doctor and you are working in a hospital or a clinic, there is a high chance of meeting somebody who contracted COVID-19, and there is higher chance of getting sick yourself. But what our paper showed is that family situation also added a lot of stress. And in May, actually starting March until the end of May, different regions were on the lockdown, and the doctors, as well as all our population, was restricted to their homes with children and husbands all together. Maybe somebody is living with their mothers, fathers, mothers-in-law, fathers-in-law. So depending on how big is the family, children went to online education at first, then the school was canceled. So it's a lot of stress. Your family is at home, you have to cook and clean 3 times, 4 times a day, and then you have to also work. And we know that many doctors were actually displaced from their homes. I'm talking about doctors who treated COVID patients in particular. But it seems like in our sample, we don't have many of them. But yeah, it added a lot of stress to the population, not data confirms that.
Can you stratify? I mean, how many doctors are there in the hospitals during those times, and how many of them are just working from home, just getting consultations from patients?
We cannot detect that from our sample. We just know that 50% of original responders did not respond to the second wave. And it might be related to the COVID-19 pandemic, or it might be just they didn't want to talk to the interviewers. Maybe they didn't want to engage in an interview.
They're right, not to. Yeah, go ahead, Sana.
Okay, thank you. So I have a question about regions. Do you have, maybe in your interview, you asked the participants about the region they live in, the cities. Do you have these findings of regional differences?
I need to pull it up. We have some information. We decided not to focus on the regional differences, but focus more on the gender differences. But there was some regional effect, of course, if the region overall is more stressed because of COVID, there would be an effect of COVID on stress. Let me just think. I need to pull it up. I can send you some information.
Okay, perfect. Thank you. So I think we out of questions and we can stop the
One more.
recording. One more question. Okay.
One more. Yeah. In your findings, you mentioned that the doctors have a mistrust to healthcare systems. As doctors themselves, as physicians, what can they do to solve this situation?
Well, actually, it was one of the answer choices, and not many doctors answered that they mistrust the healthcare system. I don't know, again, that probably maybe up to 5% maybe responded that way, but we did not include them in the analysis because it's only a few of them. So I generally don't think that our doctors mistrust our own health system.
It's interesting to find the final report or your study later on, because also in the library we conducted the same study for librarians in different regions, and we want to know also what stress factors they had or experienced during those times during the COVID-19. So there, thank you.
Did they?